One of the interesting aspects about managing patients with EGFR mutation-positive disease who are now standardly treated with an EGFR TKI in first line, such as erlotinib or erlotinib, is what to do when these patients develop technical progressive disease according to RECIST criteria, but who seem to be benefiting or only experiencing an indolent, kind of slow progression. Should we immediately change these patients onto chemotherapy, or should we think about trying to defer chemotherapy? This has been studied at the Dana-Farber by Schneider et al., who managed to identify 42 patients retrospectively who'd been treated with erlotinib in the first line for EGFR mutation-positive non-small cell lung cancer. These patients seem to have an indolent type of progressive disease that might permit the deferral of some kind of alternative subsequent line of treatment, such as chemotherapy. They found that of these 42 patients, about half of them could defer an alternative treatment by more than 3 months. Most of these patients continued directly on erlotinib. Of these 19 patients, 16 of them actually continued on erlotinib for variable periods of time, some for quite a long time, before they had to default to a subsequent line of treatment. Some of these patients did have short surveillance breaks or observation breaks when they were not on any treatment at all. Some had sort of spot welding type of palliative radiation, or even in some cases surgery. But the point was that there was a percentage of patients who could successfully defer second line or subsequent line alternative forms of treatment. However, 23 of the 42 were only able to defer the subsequent line of treatment by less than 3 months. The factors that seem to predict for a longer ability to defer alternative line of treatment included deletion 19 as opposed to exon 21, a longer PFS on first line erlotinib trended towards predicting the ability to successfully defer second line for more than 3 months. And finally, the absence of cancer-related symptoms at RECIST progression seemed to predict for the ability to defer subsequent lines of treatment for more than 3 months. So all in all, the authors of this study bring into question the relevance of strict RECIST criteria in clinical trial design, and especially question whether or not a RECIST PD is the same thing as failure of treatment. And in speaking to the principal investigator, Dr. Oxnard, afterwards, he feels quite strongly that RECIST PD is not the same thing and should not be equated with failure of EGFR TKI treatment in first line anyway, and that the doctors should use other criteria for deciding when treatment had failed, and not necessarily the strict RECIST criteria.
Thank you very much, Dr. Vincent. Are there any other investigators who are looking at the question of RECIST criteria and treating beyond PD?
Yeah, there's a consortium that seems to have been organized out of Tübingen in Germany, where their initial practice was not to offer TKI beyond PD. So they went back and got 16 patients who had not been offered TKI beyond PD, but who were felt to be comparable to a subsequent group of 25 when their practice changed, where they did routinely start to offer TKI beyond PD, even in conjunction with chemotherapy such as pemetrexed or radiation therapy routinely, and it appeared without stopping the TKI actually. So this appeared to be a sort of concurrent kind of practice. They just continue with the erlotinib and just add on various kinds of chemotherapy or radiation. And they seem to show a rather striking increment in overall survival of about 17 months, 17 and a half months, I think, compared to 2 months in the 16 patients for whom there was no TKI beyond PD. Now, this is, of course, not a randomized trial. It simply is a retrospective look at a particular experience, and an experience that involved a change in practice from not using TKI beyond PD to subsequently using TKI beyond PD. But it did seem to be associated with a substantially increased overall survival, such that would lead one to support randomized trials designed to look at this very question. And I'm not suggesting that that we simply adopt this as a standard of care in any reflex, knee-jerk kind of way, but just that if there are clinical trials looking at this question, that we should support them.